Viviane is going to discuss the perspective of Brazil regarding the severe dyslipidemias. Welcome, Vivi.
Hi, my name is Viviane Zorzanelli Rocha. I'm a cardiologist at the Lipid Clinic of Heart Institute, University of São Paulo, and also at the Molecular Cardiology of Grupo Fleury. First of all, I'd like to thank very much the organizing committee of this event of International Atherosclerosis Society. It's a really great pleasure for me to participate and be here today with you. Well, I was invited to this meeting to give you a little bit of an overview about severe hypertriglyceridemias, particularly about familial chylomicronemia syndrome in our country. But I would like to start off talking briefly about hypertriglyceridemias overall in our country. Brazil is a highly miscegenated country. But the proportion of people with high triglycerides, meaning triglycerides over 150 milligrams per deciliter, is high, similarly to what has been seen in other countries, especially due to the obesity pandemic. So there is a large longitudinal study that was performed here with over 15,000 people, showing that there is a proportion of 40% of men with high triglycerides, and among women there is a proportion of 23%, so high numbers. But the focus today is really about FCS. So FCS, as you heard before, is a genetic autosomal recessive disease caused by mutations in genes that are related to lipolysis of chylomicrons. So due to these mutations, there is an impaired lipolysis of chylomicrons. They accumulate in the blood and they can cause abdominal symptoms and a high risk of pancreatitis. So what is the scenario of FCS in our country? So recently we have started a national registry of FCS, but it is still incipient. So what we have so far is really data from individual initiatives across several academic centers in Brazil. In our center, for example, we have I believe 5 confirmed cases of FCS. In the northeast of Brazil, several academic centers reunited and they grouped several cases. I think they have the largest experience with FCS. They recently published a paper comprising 12 cases, of FCS. And they all had actually the same mutation in the GP1 gene, so probably a founder effect. So these are the several cases that we have in Brazil, but we still don't have a clear picture, a clear national picture about FCS in Brazil, since we still have an ongoing national registry about it. But I believe the journey of an FCS patient here in Brazil is similar to the journey of these patients abroad. So we have these patients that start with symptoms very early in life, generally in childhood and adolescence, but it doesn't apply to all patients. I have, for example, a patient that never actually had symptoms, and he had a diagnosis by chance a bit later in life. So this may not be the case for all patients, but overall, they all have symptoms very early. And obviously, symptoms can be abdominal pain, also an increased risk of pancreatitis, eruptive xanthomas, and also hepatosplenomegaly. These patients are also generally very thin. They don't gain weight in the majority of cases. Well, what about diagnosis of these patients? Obviously, to diagnose a severe hypertriglyceridemia is easy because you just need the laboratory exam. So I think this kind of diagnosis all the doctors can make. But what about the diagnosis of FCS? This is not very frequent in our country, only in the big centers, in the big academic centers, because people are unaware of FCS, unfortunately. They don't know about it. So they don't know about the possibility of genetic diagnosis. And the genetic diagnosis nowadays in our country is much more accessible, but people don't know about it. So they sometimes when they don't transfer the patient to the big centers, the diagnosis is not made, which is really a pity because, as you all know, FCS has singularities about the management. So since the genetic diagnosis is very often not made, the management is not correct in several cases. So as you also know, diet is really the key in these patients, and sometimes diet is not correct, it's not the appropriate diet. Many of the doctors actually use oral medications in these patients. The oral medications that we use for mild and moderate hypertriglyceridemia, fibrates, statins, omega-3, and as you know, these medications don't work properly, but they are still used in many cases here in Brazil because of an awareness about the disease. Talking about treatment still, there is plasmapheresis. We don't do plasmapheresis regularly here in Brazil because of it's not accessible in most centers. So, but it is done in selected centers in exceptional cases. So this is the situation here in Brazil. We can make the diagnosis properly with genetic testing in the big academic centers, but overall, in most parts of Brazil, it is not done correctly, and so the treatment is not proper either. So there is, we have this big obstacle that is to improve awareness so we can do more diagnosis and maybe improve the management of these patients. So on top of the difficulties related to the disease itself, we have this obstacle in Brazil, which is lack of awareness. So we need really to invest in education regarding this disease so we can improve better the care of these patients. And finally, I'd like to finish saying that we really need to celebrate the approval of the volanesorsen, the ApoC3 inhibitor, which is able to reduce significantly the levels of triglycerides in these patients. This medication was approved by our regulatory agency, Anvisa, but we know we still have a very big struggle, which is the access to the medication for our patients. So this is our next battle. I hope we can really turn it possible here in Brazil. So I'd like to finish. I hope this information was useful for you, and I'd like to thank you very much for your attention. Thank you.
Thank you very much, Viviane. That's an excellent and I believe totally not understood portrait of really how hypertriglyceridemia is being managed here in Brazil. Of course, the patients that we see usually get here very late, especially those with FCS, with many episodes of previous pancreatitis, and definitely it's a real challenge to deal with this patients. So actually we have two questions here from the audience, Vivi. I think one I'll answer, the other one I'll leave it to you. So the first one is from our colleague Shamana Iyengar. And actually the question is it necessary to measure triglycerides if ApoB is normal? Actually, yes. Because actually hypertriglyceridemia may be of accumulation of ApoB48, so chylomicrons and chylomicron remnants, and ApoB100 should be normal, but we might have hypertriglyceridemia. So definitely yes, actually these are complementary tests. Now, Viviane, there's a question for you here. Actually, it's a little bit outside the scope of today's webinar, is much more for tomorrow. But anyway, it's from Veronica Isano, and she's asking about a 7-year-old boy with a total cholesterol of 6 moles, should be around 240, an LDL of 4.50 millimoles at around, let's say, 160, HDL of 90 milligrams per deciliter with normal triglycerides, zero point 0.7, that should be maybe around 140. And actually, the question is that her carotid IMP is normal, echocardiogram is normal, but the patient mother, who's a young person, 29-year-old, has a total cholesterol of around 8.46. That should be around 340 milligrams per deciliter, on LDL of almost 190. Actually more, 280 milligrams per deciliter. And with normal triglycerides. So the question is if this patient should be suspected of being FH.
Hi, Raul. Do you hear me well?
Yes.
Okay. First of all, thank you very much for the invitation. It's really a pleasure and honor for me to be here participating in IIS. Well, related to the question, I think for sure, I mean, this is a woman, a young woman with a very high LDL cholesterol. This is compatible with FH. Obviously, it would be great if she could undergo a genetic test to confirm that, and then we would apply that to the boy. But if a genetic test is not available, I think her LDL is really compatible with FH and also the boy's LDL cholesterol, right? Around 160. A child with 160 or more and with hypercholesterolemia in the family, or family history of CAD, premature CAD, is really a very high suspicion of for FH. So definitely we should suspect, and we should start treating the woman and the boy above 8 years old.
So I'm going to ask another question, Vivi, coming back a little bit to triglycerides. I think Dirk gave us an amazing talk about the therapies, the pharmacological therapies, but unfortunately, so far, we have bologna sourcing approved here in our country, but it's not available. And I really like to emphasize the importance of the low-fat diet for people with FCS, because that's the only thing that we can do for these patients. Can you comment a little bit on this?
Yes, Raul, this is really very important. And I think, as I said in my little talk, it's very important that the correct diet is emphasized, because sometimes because people don't know that actually fat is the key in the diet for FCS, people just actually cut carbohydrates and they leave the fat. So this is not the proper diet, and it is really the key. Sometimes you cannot maybe control fully the patient only with diet, but it's really the most important treatment for sure. And I think it's the most difficult part for everybody, unfortunately. So it's really a coincidence, because yesterday I got the exams of a patient that I have. She doesn't have the genetic diagnosis of FCS, but she was having, she probably has a genetic background, maybe polygenic hypertriglyceridemia, because her genetic test only had a variant of unknown significance. So she didn't have like a confirmed FCS diagnosis, but she had like more than 3,000 milligrams per deciliter of triglycerides. And she started really doing the diet, and she went down to less than 100 milligrams per deciliter of TG. Of course, she doesn't have like a FCS confirmed, but like a behavior that is kind of similar. She's a very young woman, and with diet, she really could control very well. So it may not be the case for all FCS, but it's really the key, for sure.
Yeah, exactly. Thank you. Thanks so much. Actually, this week I have a patient that I believe is multifactorial chylomicronemia, because she's a little bit overweight and she had a pancreatitis episode. And so this is really emphasizing the need to really adequately control the triglycerides. And I remember last time I saw her, we did a teleconference because of the pandemic, and she said, look, I have my xanthomas. I didn't do my test, but I know my triglycerides are very high. So actually, I think we should also call the attention for the eruptive xanthomas as an indication that triglycerides are extremely high, and the patient might have the risk of getting into a pancreatitis episode. And now she's admitted at the hospital. She's doing fine, fortunately, but it's always complicated. No, pancreatitis is not let's say, a simple disease, and you might even die of it. So that's very issue. Okay, Viviane, thanks so much. So basically, guys, what I'll do now is very quickly to give a summary of what have been the 3 presentations. So Rodrigo actually was very happy in